Hi guys! Today I want to talk about immune-mediated thrombocytopenia. Basically a fancy way of saying the body attacks the own platelets and can lead to bleeding that can be very severe or even fatal. If you haven't watched my video on immune-mediated hemolytic anemia or IMHA, please go back and watch that first. A lot of what I'm going to cover today is very similar to that disease, and so I'm going to go pretty quickly with some of the information here. Typically when we see patients with immune-mediated thrombocytopenia, they come in for evidence of bleeding. They can have bruising, they can have little pinpoint areas of bruising on their skin or very large areas of bruising, or they could actually come in with frank blood from their nose, from their mouth, and the vomit, diarrhea, anything like that. Sometimes we find the bleeding in the chest or abdominal cavities, and sometimes they actually present for the signs of anemia because they've bled so much that their body is really struggling to circulate oxygen and nutrients. Most of the patients with this condition, like IMHA, don't have an underlying cause, so still about 85% we don't find anything that caused it. The minority of cases, so about 10 to 15% of cases, will have either a medication, vaccine, cancer, infection, something along those lines that have caused it. And so we typically recommend the same workup that we would for the IMHA. So if we can do everything, we want to make sure that we have chest x-rays to make sure there's no cancer in the chest. Abdominal ultrasound looking for any evidence of cancer or infection in the belly. Blood testing to look for evidence of tick-borne or infectious diseases. Ideally we get a urine sample on these guys, but if we have to obtain it with a needle or anything traumatic, we want to try to avoid that because of the risk of bleeding. So in that case, we usually will hold off unless we can get like a free catch sample, or unless we got a sample before we knew. And that's really scary. In some cases, a lot of samples are drawn before we realize what's going on. But again, most of the time we have a sense because they come in with bleeding. The treatment is often going to be the same as IMHA, although I feel like these patients tend to come in a lot sicker. Because of the bleeding, they not only have no platelets to kind of control that bleeding, but they also have anemia that we have to fix as well. And so these guys often will get blood transfusions of red blood cells so that we can keep their body happy, their organs perfused while we're waiting for the platelets to come up. There are platelet transfusions that can be given, but those platelets don't last very long, and so typically we're not giving platelet transfusions because we may only get a couple of hours of relief, if that. So typically what we're doing is supporting the body with fluids and medications, blood if we need it, while we're waiting for those platelets to come up. Immune suppression, again, is going to be our treatment, our gold standard treatment. So we're looking at steroids again. That's the gold standard medication, but we're also adding in other medications to suppress the immune system, like cyclosporin or azathioprine or mycophenolate or leflunomide. So there's all these different medications that we can add in to help the steroids work on suppressing the immune system to get the body to stop attacking the platelets. Those medications aren't going to work instantaneously, so again we're looking at 3, 5, 7 days, sometimes even longer than that, and often we don't know which patients are going to survive until we give them that time. If they're having a lot of bleeding through their gastrointestinal tract, so either frank blood in the stool or digested blood, that dark tarry stool which we call melena, or vomiting up blood, those patients tend to, in my opinion, be a lot more difficult to control because the surface area in the gastrointestinal tract is so much that often they bleed and we can't keep up with that bleeding. But again, it can take 3 to 5, 7 days, sometimes even longer than that for our medications to kick in, and so we're doing everything we can to keep them stable during that time. Once they have a stable anemia, so this is where it gets a little bit tricky. We definitely want to monitor platelets, and again we're looking for a platelet count of at least above 40 to 60,000 because that's usually the threshold where we see the bleeding stop. And oftentimes I'll know or have an idea that the platelet count is up because they stop bleeding and their red blood cell percentage stays stable. So we're looking for 24 hours at least of stability before we send them home. And then it's usually a week or a few weeks before we see their platelet count return to normal. And so I really want to keep them in the hospital during that time until their platelet count is above 40 to 60,000. That way they're stable at home and my owners don't have to worry that there's going to be a problem. Once we get their platelets into a normal range, which on the IDEX blood panel that I use is at least 143,000. Once we get them to that point, then we start to slowly, painfully taper their medications one by one while we watch their platelet count closely. I would still say we probably see, 70% of patients go into remission, but if you look at the literature, it can be 50-50 in some cases. Once we get them into remission, they often stay in remission, but again, there are some patients that as we taper their therapies, they'll come out of remission. And then typically, if we can taper them off all medications, it takes about 3 to 6 months, but often those patients will go on to live normal lives. But again, we try to be careful as far as what we give them in the future just to try to prevent this from coming back. And so I tend to be a little bit wary of vaccines. I tend to be wary of certain antibiotics, things that we know that can trigger autoimmune diseases. But we always have to factor in the patient's lifestyle, their risk factors in those recommendations that we make. So anyway, I hope you guys enjoyed this video. Again, if you haven't watched my other video on immune-mediated hemolytic anemia, I would definitely do so. There's a lot more detail there. And really what I wanted to point out with this video was some of the differences and similarities in these two autoimmune blood disorders. Thank you.